and then do questions and answers. So this is, oh no, what am I?
We may have just lost our presentation.
Yeah, so hold on a second. This is Dr. Alexis Eastman from UW-Madison. Please give her a warm welcome.
Hi, guys. Well, if we never get the screen back, oh, there it is. I was going to say I could do interpretive dance. It's a little awkward. So for those of you who don't know me, I'm Alexis Eastman, your friendly neighborhood geriatrician. I do geriatric primary care mostly at UW, but I also do some memory care, some other subspecialty things, and I'm the medical director of Badger Prairie, which is the best nursing home as far as I'm concerned. No bias. So I am really super excited to talk to you today about dementia, and not necessarily the most uplifting of conversations, but we'll try to make it worth your while, and I'm leaving plenty of time for questions at the end because I think the conversation is a really valuable part of this whole thing. So without further ado, when I'm talking about dementia, the first thing I think is important to talk about is, what is it? Right? I think we all have a lot of thoughts about what it might mean, but it actually has fairly strict definitions. So when we talk about what it is, we should also talk about what it isn't. What happens to your brain as it gets older normally, right? The normal aging brain is allowed to forget things. That's okay. They should be occasional and temporary lapses. That's fine. It is perfectly fine to walk into a room to look for your glasses and then realize they're on your head. That's perfectly reasonable. When we think about the way the brain functions and what changes with age and what stays the same, the things that get slower or slow down or change at all are things like processing speed, multitasking, quick recall, right? Those all slow down. But things that should stay the same are vocabulary and your fund of information. So when I'm talking to patients, I say, your brain is like a library. You've spent 80-odd years stuffing facts into it in no particular order. So when you go to pull a fact back out, it should take a lot longer because you're shuffling through all the detritus of all the other stuff. But the book should still be there, right? So if the books in the bookshelves start disappearing, then we have a problem, right? But it's not just memory. If you come to memory clinic, we look at a lot of different things that are not strictly memory because cognition is this huge multivariate thing. We talk about immediate recall, which is very short, actually. It's whether or not you've remembered my name from 2 seconds ago, right? Versus delayed recall, which is anything longer than 30 seconds. So anything from your grocery list to your childhood is delayed memory, long-term memory. So long is a very broad category. We talk about attention, which is your ability to stay on task and stay focused. Visual, spatial, and construction skills, your ability to kind of envision things in space, draw objects, copy objects. Language, can you get the words out? Are they the words you want to use? Can you repeat them back to somebody? Do you still know all the same words you used to know? A very broad category called executive function, which is navigation, problem solving, complex tasks, things like driving, cooking, brushing your teeth, or just figuring out, is this the right decision? All of that falls under executive function. And then finally, orientation is a whole separate part of brain function. So who you are, where you are, what time is it? All of that is in one particular section of the brain. So all of these are different types of cognition. So when we're talking about dementia, we're talking about cognition and all these different things, not just memory. So another more technical term for dementia is major neurocognitive disorder. That's what we call it in the textbooks, right? It's just really hard to say, so we usually say dementia because it's shorter. But major neurocognitive disorder is a deficit, an impairment of any two areas of cognition that gets in the way of your day-to-day life and is a change for you. So it doesn't have to be memory. It could be attention and visual spatial skills. It could be judgment and language. It could be memory and something else. It doesn't have to be specifically memory to be dementia. So why all the confusion? Well, dementia is an umbrella. And when most people think of dementia, they think of the most common kind of dementia, which is Alzheimer's disease, right? Alzheimer's is just one type of dementia, but it is the most common, and it is the one that is associated with memory loss. So that's what we all tend to think of when we think of dementia. But there's also a vascular dementia from small strokes. There's also Lewy body dementia, frontotemporal dementia, alcohol dementia, and many, many, many others. This is one of those places where if you put 5 memory doctors in a room, you're going to have 7 opinions on how many dementias there actually are. Roughly 38 to 42, depending on the day and who's talking. I think there's 38, but, I've been argued with before. It's fine. So that's why we think dementia is the umbrella and Alzheimer's being common. That's why we think memory is the issue. But it really is a lot of other different things, and we have to be aware of that when we're looking at what does it look like if you develop a dementia. Why do we care? Well, I probably don't have to tell an aging audience why we care about worrying about dementia, right? We're all terrified of it. It's a hard disease. 1 in 3 of us will die with it, even if we don't die of it. That's a lot of people. Every 65 seconds, someone in the United States develops dementia. That's wild. It's a terrifying number. And it kills more people every year than breast cancer and prostate cancer combined. Alzheimer's, the most common kind of dementia, is the 6th leading cause of death in America. 6th leading cause. And we don't talk about it enough. So here I am. We're going to talk about it. So what are we going to look for? Right? Here are some signs and symptoms of dementia. And I should preface this by saying there are also the signs and symptoms of a lot of other things, right? So don't look at any one of these and go, oh my gosh, that happens to me, I must have dementia. Don't do that. That's a bad idea. But just keep these in mind as potential red flags that warrant further investigation. How about that? So first, we'll talk about the memory side of things, different types of forgetfulness. Forgetfulness should warrant some investigation. Not just the why did I walk into a room forgetfulness, right? That's okay. Don't worry about that. But things like familiar people, if there's someone you've known forever and suddenly you don't remember who they are, that should be a topic of some concern. Maybe more for them than you. It depends how much you like them. But it should be some concern. If you're forgetting important events, if you're forgetting times and locations of things that you want to do or want to go to, if you've forgotten how to get somewhere, especially how to get somewhere familiar, like, the next door neighbor's house. If you're forgetting your appointments, I'm biased, I don't want you to forget an appointment with me, but if you forget appointments with important people or non-important people, you should be concerned. If you're redoing tasks you've already completed, if you buy 2-3 sets of airline tickets for the same flight, for example, that's a problem. Not only are you out a lot of money, but you should be concerned about your memory. And if you're rereading things over and over and over again and be like, I just can't get it to stick in my head. I don't remember the theme of that novel, and I know I've read it 20 times, just in this week. Again, these should be frequent events. They shouldn't just be one-offs, right? They should be frequent events that are increasing in frequency, that are intrusive, getting in the way of your ability to get through your day. Right? That's a theme to think of. Not just the occasional thing, but a theme of frequent and increasing and intrusive. What else can change? Well, language can change. So some of the symptoms of dementia are things involving the way we speak and the way we understand language. And it's not just the tip of the tongue moment. It's fine to be like, her name is Anne, that's right. Totally normal, right? That's a totally normal thing. Again, you're pulling a book out from the dredges of your mental library. But if you're forgetting regularly familiar names, if you can't finish sentences regularly, where you stop halfway through and then the last half of the sentence is totally gone, just again and again and again. If you can't get the words to come out of your mouth, right? You know what you want to say, you're trying to, and it just won't happen. If you can't write, if you try to tell your hand to do something and your hand is not doing the thing, if you can't understand others, if you think they're just doing a whole bunch of gibberish and you're like, I don't know what's going on here. Or if you can't read, if you're looking at the words and you can't see them anymore, like visually, you should raise your concern. If words you don't mean to say start coming out of your mouth, and you mean to say one thing and a totally different sentence comes out, you're hopefully polite, hopefully not totally getting you in trouble, but got to be prepared for that. And those are things to watch out for. So again, frequent, increasing, and intrusive. So again, not just happening once in a while. We all say things we don't mean to say, right? If you're doing it every day, though, that's a problem. Changes in problem solving and navigation can also be significant. So maybe you can't follow a recipe anymore. Maybe you suddenly have to use a recipe, and you've been able to make Toll House cookies since you were 5. Thank you very much. So why should you have to look at the back of the bag now? Maybe you've lost or overpaid your bills. They'll never give you the money back. You ever notice that? Maybe you're falling for multiple scams. It's easy to fall for one scam, right? Scammers target older people specifically. And if they target you on a smartphone, those phones are smarter than we are. It's very difficult to sort all of that out. But if you fall for them again and again and again and you've lost significant amounts of money, that should be a sign of concern. If you get lost while driving, even if it's somewhere new. If you have lots of checkbook errors or you have problems doing your taxes and you're a retired CPA, for example. If you can't use familiar devices, if you've been using the same television for 15 years with the same remote to watch football every week and suddenly you can't figure out how to use the remote, that should be a concern. And if you no longer are doing your household chores, if you're the person who vacuums every Friday and you haven't vacuumed in 5 months and someone's like, wow, there's some dust here and I've never seen you have dust in your house, that's a moment of concern. Sometimes personality and behavior changes. So you have to watch out, not just that you're set in your ways, right? One of my favorite patients once said to me, she said, as you get older, you just become more so. Whatever you are, you just become more so. All right. That's what we do. That's fine. That's okay. But if you notice that maybe someone you love is becoming unreasonably stubborn, like, why are you so stubborn about this tiny little thing? If they have no interests at all, right? Everything they used to like to do, they just have no time or interest for, like, eh. If they have explosive anger, so out of nowhere, just rage. If they have decreased hygiene, like no showering, no washing, no changing of clothes. If they develop ritualized behaviors, they want their sandwich with the crust cut off, cut into triangles every day at 12:30, and it must be the same kind of creamy Jif peanut butter that they've always had, every day like that. If they have inappropriate emotional responses, where you're watching a sad movie or at a funeral and they just start laughing hysterically, inappropriate emotions. Becoming hypersexual, becoming aggressive, or becoming really needy when they weren't before. So again, different, something that's changed, something that's intrusive, something that's getting in the way of the quality of someone's life. Vision can change as a sign of dementia. So remember, we talked about visual spatial skills as being one type of cognition. If you can't read because you can't either make sense of the word or you can't see the word or you can't process the word, any sort of reading changes, at least warrant a trip to the optometrist if nobody else, right? If you have peripheral vision loss, if you can't tell what you're looking at that nice vase of flowers over there and you're like, I don't know what that is. If you're seeing things that other people don't, especially moving objects, small creatures, little people in the corners of your eyes, flashes and floaters usually pretty common, but any sort of formed thing, especially little creatures, should warrant some concern. If you've suddenly lost your color vision, right, that's a big change. If you've lost your depth perception, you don't know how far away the car in front of you is, that's a problem. Sleep can also change. So maybe you have new insomnia. You've slept great your whole life and now you're wide awake all the time and it's driving you crazy. That warrants investigation. Maybe the other way around. Maybe you've always could have been a night owl, but now you're sleeping all the time, like a cat, 27 hours a day, right? Maybe you're sleeping at the wrong time. You're at a wonderful presentation about dementia and you just fall asleep. Of course, you guys just had lunch, so I'm not sure this counts, right? It's a thing. Maybe you have intrusive dreams. You always had nice dreams before, but now they're just like wild and weird and they're very confusing and very scary. It sounds weird to say you need to go to a doctor for you're having bad dreams, but maybe you do. Especially if you're acting them out. If suddenly you're in a football game and you wake up and you've tackled the dresser. That's a true story, by the way. You should get help. If you're dreaming while you're awake, if your dreams start bleeding into your waking hours, or if you have new restless movements, if you're kicking your spouse in bed and you never did that before and they haven't started snoring, this is a reason to get some investigation here. And then finally, movement changes, while not necessarily connected to dementia at all, can be signs that something else is happening in the brain that needs investigation. So it's important to pay attention to movement changes. So new tremor. Now, the caveat that lots of people have a tremor. Lots of tremors are completely harmless and completely normal. It's fine. But if it's new and it's different, you should ask, right? If you have trouble moving your limbs, if you have trouble moving one limb, you should get yourself to the emergency room because you've got to get a stroke rule out, right? But if you just feel like things are just not globally moving the way they used to, you're all stiff. Maybe you're having problems with balance that you didn't have before. Maybe you're having problems walking that you've never had before. Maybe you're falling a lot, especially if you're falling backwards a lot. It's always very awkward if you've done the good thing by getting yourself a walker and then you fall backwards and you take the walker with you. It's so disheartening, but it does happen, and that should warrant additional concern. If you have trouble holding yourself up, if you're just sitting at the table and you're just like, oh, I can't even get my shoulders to stay in the same place. If you're losing sensation in any of your limbs, or if you've suddenly developed kind of jerking motions and you're accidentally punching people, all of these things warrant concern. There are lots of different causes for all of these things, but they're all things you should pay attention to. So now that you think about those are the potential warning signs, what do you do with that information, right? I've noticed these things about myself or about someone I care about, and I don't know what to do with this. So here's a handy guide on what to ask your primary care doctor or provider of any type. There's a lot of things that look like dementia, and you're going to want someone to rule those out before you get a label, right? And so it's really important to ask these questions. Is there any sign of depression, sleep apnea, thyroid disease, liver disease, anemia? There are certain vitamin deficiencies, infection, cancer, electrolyte issues, and parathyroid disease. There's a lot of things. There's other mimics too, but these are some of the most common mimics of dementia that we see, all of which can be treated, all of which can be tested for. So that's an important series of questions to really talk about with your primary care provider. The other thing you're going to want to talk about with your primary care provider are your medications. Because there are medications that can mimic dementia, and there are medications that not just mimic dementia, but increase your risk of getting dementia. And so we're going to give you some examples now. So medications that can look like dementia are, as you might imagine, sedating ones, right? If you're kind of loopy, you're not going to look like you're wholly with it, right? So that's a good category of things to keep in mind. And the category of medications that can both mimic dementia and increase your risk of dementia is a whole broad spectrum category of things called anticholinergics. Unfortunately, there's a lot of anticholinergics, and we use them for a lot of things. That includes older generation antihistamines, tricyclic antidepressants, and almost all of our bladder medications. This is one of those evil insults of aging is the aging bladder, right? It's really out to get you. And we have a lot of pills for them, but they're not safe. And that's really difficult. Now, every medication has a time and a use, right? I'm a geriatrician. We're very cynical creatures. We think all medications are evil. But you have to pick the evil that is appropriate for your disease, right? There are uses for medications, but you have to know that everything has a risk. So these are some of the sedating medications that can look just like dementia. So Valium, Xanax, lorazepam, pain medications like oxycodone and hydrocodone, gabapentin, Lyrica, tramadol, Nucynta, and then some of the sleeping medications because they're supposed to put you to sleep. But sometimes things like Ambien and Lunesta and all those other medications last a long time and have some spillover hangover effects the next day. Now, again, there's maybe a very good reason that you're on gabapentin, and maybe you need to be on gabapentin. But just know that if you're on too much, or you've been on it a long time, or you don't need it, maybe you should get off of it because it can make you look like you have brain changes. But if you stop them, your brain gets better. These do not linger permanently, right? So that's good to know. Older antihistamines. Benadryl. It doesn't seem like Benadryl's that dangerous. It's over the counter. These are all over the counter, right? Benadryl's fine if you're 20. When you get older, the barrier that protects your brain gets leakier. And so all these medications now get into the brain a lot more than they used to and cause more damage. Secretly, anything that has a PM in the title is also Benadryl. because PM is diphenhydramine, diphenhydramine is Benadryl. So all of your sleeping meds that say Tylenol PM, there's a reason it puts you to sleep. It's Benadryl. Chlorpheniramine, scopolamine and meclizine, things for vertigo and motion sickness. Atarax, which is for itching, it's hydroxyzine. Unisom, Dramamine. All of these are old antihistamines that get into the brain a lot more and can make you confused. They also dry you out. That's part of their purpose. They can also make you fall over. There's a lot of other different side effects of these, and they can also increase your risk of developing dementia. Much safer alternatives include the newer ones, loratadine, fexofenadine, cetirizine. These are much safer drugs than Benadryl and its family. So something to keep in mind. Now, all of these are safer than certain big gun medications, right? It's all, again, about choosing your level of risk. Tricyclic antidepressants. Again, sometimes you need to be on one, right? This is nortriptyline, doxepin, amitriptyline, imipramine, which is tofranil. There is a time and place for all of these. However, they do come with some risk. And finally, the bladder medications. Boy, they're useful, though. That's the problem, right? When they work really well. When they don't work, who cares? But these are things like oxybutynin, Vesicare, which is solifenacin, Enablix, which is darafenacin, Detrol, which is tolterodine, and Toviaz, which is fesoterodine. They have their time and place, but they also can mimic dementia and increase your risk of developing it. What's safer? Longer-acting versions are safer than shorter-acting because it's time release instead of that big flush of medication all at once. Myrbetriq, or mirabegron, is totally safe. It's also really expensive, but it's totally safe. It's in a different class of medications. And we think trospium, which is Sanctura, is safe. We don't think it gets into the brain the way the others do. So there's some options. So when you're seeing your primary care provider, and you're worried about your cognition, you want them to run tests to rule out other causes. You want them to do a good medication review. And you want them to do some sort of cognitive screening, right? There's our short office-based tests, maybe 30 seconds, a minute, 5 minutes, 10 minutes, depending what your primary care provider knows how to do, that will help determine if they're seeing the same thing you're seeing. And if you go through all of that and you say, okay, we're seeing something here. We've ruled out medications, we've done all the right labs, but there's still a problem. That's when you come to memory clinic, right? That's when you ask them for a referral to one of the memory clinics. I'm agnostic. I don't care whose memory clinic. It doesn't have to be UW's. It doesn't have to be St. Mary's. It doesn't have to be anybody's. Just a memory clinic, right? How do we diagnose dementia? Well, this is essentially the whole process, the whole list. It's a long visit. I've never seen a memory clinic visit go less than 90 minutes, and usually it's 2.5 hours, something like that. They're big gun visits. If the labs have not already been done, they need to be done. Memory clinics do more in-depth cognitive testing. Some places it's an hour, some places it's 2 hours. I've even seen 4 or 5 hour memory testing. It's brutal, but they test every bit of your brain, right? You walk out of there with just like a full brainoscopy. They do a physical exam. They may need other imaging, a CT, an MRI. There are even PET CTs that we use for Alzheimer's disease and frontotemporal dementia. Some places do lumbar punctures, which is useful in Alzheimer's and only Alzheimer's. And there are some new tests that are coming out, not quite for prime time, but coming out soon. Blood tests. Wouldn't that be great? A blood test for Alzheimer's, and something called a PET amyloid scan. So if you're at memory clinic, at the bare minimum, these are the things that must be done. You must make sure that all the labs are done, that you've gotten good cognitive testing, and that you get a good physical exam, right, to make sure we're not missing something. In some cases, these additional things are very helpful. We may want to do a CT or an MRI to make sure you don't have a brain tumor, to make sure that you haven't had a stroke, to make sure everything in your brain is what's supposed to be there. We may need to do a PET CT. A PET CT looks at the sugar uptake of your brain. And dead brain areas, damaged brain areas, don't take up sugar very well. And so we can look at that pattern to help us determine what kind of dementia or brain disease you might have. And this really only works best for Alzheimer's or frontotemporal dementia. So that's what we use a PET CT for. Lumbar puncture, where they take a needle and they go into your spinal column and grab a little bit of fluid, it's not as bad as it sounds. It can be useful in Alzheimer's disease. And then almost ready for regular use. There are blood tests for Alzheimer's. They look at the amyloid in the blood, which is a molecule for Alzheimer's. That's almost here, maybe by next year. Not sure. It's going to be an interesting adventure to figure out how exactly to use that. And then there's something called a PET amyloid scan, which looks at amyloid and Alzheimer's in your brain, much like a PET CT does with sugar. So that's also coming. It's not approved yet, or at least it's not paid for yet, I should say it. We do use them, but it's not covered by Medicare yet. So you've gone through all of that, and you've had this long talk with multiple people in this big multidisciplinary clinic visit, and they say, okay, you do have a dementia, one of the 38 different kinds. Well, now what, right? What do we do to treat dementia? So here's the current lay of the land in terms of treatment. Sadly, it fits on one slide, right? So we have three basic categories of medications. The first is a group of medications called acetylcholinesterase inhibitors, say that 10 times fast, and they are donepezil, rivastigmine, and galantamine. And they increase a molecule in the brain called acetylcholine. So acetylcholine is one of the molecules your nerves use to connect to each other and communicate. So by increasing the amount of acetylcholine, they make it easier for your nerves to talk to each other, which makes it easier for your brain to work when it's having difficulty. It slows down cognitive loss to be on one of these medications. It doesn't stop it, but it slows it down. It buys you time. Side effects, there's always side effects. Not too many. Some stomach upset, slowed heart rate. Sometimes it causes anxiety. They all cause wacky dreams. It's weird. I don't know why, but they all cause wacky dreams. The second class of medications is actually just one medication. It's memantine, otherwise known as Namenda. It's something known as an NMDA receptor antagonist. And NMDA is another molecule that helps your brain nerves connect. And we're not quite as sure how that works, but we do know that memantine and things very similar to it alter the way NMDA works in the brain and does the same thing that donepezil and rivastigmine do. They slow down cognitive loss. Mostly the same side effects. Memantine's a little bit more sedating. They both give you wacky dreams. They both give you some stomach upset. Not very often, less than 10% of the time, right? So 90% of people do just fine with no side effects at all. And then finally, statins. And not because we care about your cholesterol. I'm sure your cardiologist cares. But because statins in people with vascular changes to the brain actually smooth the blood vessels to the brain. So they improve blood flow to your brain. And improving blood flow to your brain can only be good for brain thinking, right? So that's why we use statins in memory diseases, certain types of memory diseases. So not everybody, but some people need them. So that's our medication. Our medications have limits, right? Unfortunately, they're pretty much all designed for Alzheimer's disease, which is, yes, the most common dementia. We may use them in all of the other dementias because those are the medications we have, and they're better than nothing, right? And sometimes they work very well in certain things like Lewy body dementia, for example. We'll use donepezil or rivastigmine, and they do work. Progressive supranuclear palsy, for example, another place where rivastigmine can be very helpful. But they don't stop the disease. We cannot cure dementia. We cannot reverse it. We can slow it down. So that's the best we in modern medicine can do for now, right? You've probably heard all of the news articles about the new kids on the block, aducanumab, lecanemab, trade names Aduhelm and Leqembi, these very expensive infusions of monoclonal antibodies that soak up amyloid, not without side effects, and while they've been approved, are not approved by Medicare yet. So I think stay tuned, don't go rushing off, because unless you have $60,000 sitting in your pocket you're not doing anything with, which is about what it costs a year to get one of these medications. So just maybe, but know that they're out there. Know that we're working on things, and that day is coming. But what else can you do? Well, if there are any of my patients in the audience, they know that I will pound the podium of exercise endlessly. Keeping your brain active, very important. And getting enough support, right? This is a team sport. You got to make sure everybody's on board. Exercise, 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 exercise. It is as good as our memory medications, right? You can slow your disease down as much as donepezil will just through regular exercise. At least 6 months. It'll buy you at least 6 months, maybe longer. And there are no side effects, right? It's far safer than anything I can prescribe. Exercise. How much? 150 minutes every week. Now, I don't care how you divvy that up. You can do 15 minutes 10 times a week. I do whatever, you can just 1 minute 150 times. That's hard to keep track of, but you can do it. And any exercise is good exercise, right? Do whatever you can. Keeping your brain active. Once you have a diagnosis of a dementia, you want to keep the brain going. This is where brain games are important. They're less important as prevention, but they're more important once you have a disease. You want to keep your brain stimulated. You want to stay socializing because social activity is a really important part of brain activity. And it keeps you on your toes because people never say what you expect them to say, so you got to think, right? Very good for your brain. But you want to be cognizant of the fact that if you have dementia, your brain's more vulnerable. It doesn't handle chaos as well. It's already working pretty darn hard just to exist. So you want to give yourself lots of time for breaks, and you want to avoid overstimulus. You want to just make sure you're not at the fun fair and all the lights and the bings. I mean, that's bad enough on a good day, right? Not on a day when your brain is not working. People always ask me about supplements. Supplements work great in mice. We are not mice. There are no proven supplements to help in humans. So some of them aren't studied, but those that are studied, there are no good studies that show that any of them work to slow down memory loss. If you truly have a vitamin deficiency, like a true one that you can see in labs, then yes, you need a supplement. But otherwise, not going to help you. Exercise instead, save your money, right? It doesn't hurt you usually, but it will hurt your wallet after a while. Some of those things are really expensive. So I kept that part of the talk is short, right? So the more important part of the talk is, how do I not get dementia? Right? That's what people always want to talk about. I can't make your risk zero, right? I can't do that. I can't say if you do these 5 things, you will never get dementia. That's not even possible, right? But you can lower your risk. And you don't need me to do it. So there's things you can't change, right? You cannot change your age. I'm sorry, there's no pill for that. You cannot change your sex. You cannot change your genetics. You can blame them all you want, but you can't change what your parents gave you. And you really can't change the past, right? All of your wild past experiences. Enjoy the fact that you had them. You can't make up for them now. But there's lots of things you can change. You can change how sedentary you are. You can change whether or not you smoke. Please don't. You can change how much you drink. You can change whether or not your diabetes is under control, whether or not your blood pressure is under control, how you're doing with your mood, whether or not you're socially isolated. Nobody here is, so this is good, so thank you. How you're sleeping, how you're hearing. Basically, you can change the future, and you are never too old to reduce your risk. Right? So, we think your risk is about 35 to 50% modifiable. That's not bad. You can reduce your risk by 50%. Not too shabby, depending what you do. So the first thing you can do is back to the slide. See, pounding the podium. Exercise. We have known that there's a connection between low exercise and dementia for well over 20 years. Well over 20 years. In fact, the first trial on the benefits of exercise and dementia was in 1978. So we've known this for a long time. And there are many studies, some of which are done at the UW, some of which are still ongoing at the UW, that show cognitive benefits of exercise in every age group, right? Good for everything, bad for nothing. There's this paper from the Journal of Scandinavian Sports Medicine, which I did not know was a journal, a scientific journal at all, until I saw this article. It was exercise as treatment for 26 different conditions. And it just lists them and gives you the evidence. And it's an amazing paper. It's good for everything, bad for nothing, no side effects. But why? Why does exercise work? Well, it does increase blood flow to the brain. It decreases stress chemicals in the brain. It improves the building of new neurons. You're never too old to build brain cells. It improves the connection between brain cells and all of the other support nutrients that get into the brain. It also improves your mood. You get that rush, you're less depressed, you're less anxious. And it improves your hormone responses. So it decreases stress hormones, it improves blood sugar, all of these good things. So it improves all your risk factors. So your exercise, again, 150 minutes every week, break it up how you want, can drop your risk of Alzheimer's by over 40%. That is better than any pill I can give you. What's the best exercise? That's the next question. The best exercise is moderate You want to be able to talk but not sing. I didn't say sing well, I just meant not sing. For brain health, you want some aerobic activity. For bone health, you want some strength training activity. But at the end of the day, the best exercise is the one that you'll actually do on a regular basis. I do not care what it is. Just do something. Right? The next thing you can do is diet. And this is a good quote. It's Michael Pollan. Eat food, not too much, mostly plants. Right? It sums it pretty much. The Mediterranean diet is the most tried and true. It's got the most evidence for decreasing vascular risk factors, and vascular risk factors are dementia risk factors. They're almost all entirely the same, minus some genetics. So that's really whole grains, fruits and vegetables, nuts, and then anything you can buy at the county fair should be limited to the county fair once a year. Okay. Now, lots of people have heard about the MIND diet. What is that? The MIND diet stands for Mediterranean/Intervention Neurodegeneration Diet. They really squeezed that into one acronym. And it's pretty much the Mediterranean diet with some brain healthy foods and some best avoided foods, essentially Mediterranean diet plus more nuts and berries. All right, we can do that. They're very, very similar. I've put up the two different things, whole grains and plant oils on the Mediterranean, leafy greens and vegetables and whole grains on the MIND, fruits and vegetables, berries, nuts and beans, plant oils and seafood. And then, so just a bit, either way, the sinful foods are still always at the top, right? Everything that you crave, it's all up there. So the MIND diet's a little bit better. When we look at the evidence, they did a big study in Chicago looking at people who stuck to the MIND diet, and the people who really stuck to the MIND diet, like really stuck to it, had a 54% lower risk of developing Alzheimer's over 10 years. Not shabby. And these were older people. These weren't like 40-year-olds. So not so bad to just eat your fruits and vegetables. I say in Wisconsin, the land of cheese, but cheese has its place. Hearing is an important thing. We think up to 9% of your Alzheimer's risk is related to untreated hearing loss. And you're like, well, how does that happen? Well, hearing is a whole brain activity. So those are all the different sections of the brain that are involved in hearing something, hearing and understanding. So there are many theories about why hearing loss might increase your risk of getting Alzheimer's. So the first one is that maybe it's a common pathway. Maybe the vascular risk factors that may increase your risk of Alzheimer's also increase your risk of losing your hearing. Maybe it's just a twofold process. Maybe it's that your brain has nothing to do, and so it stops working, and you get less resilient to developing Alzheimer's. Maybe it's because it takes so much work to try to hear something that it overwhelms your brain and makes it vulnerable to disease. Or maybe it's some mix of all of the above. We don't actually know. Studies are ongoing. Watch this space. But we can preserve the aging ear. So the first thing is the ear, like the eyeball, is full of little tiny blood vessels. So anything you can do to improve little tiny blood vessels is good for your hearing, is good for your brain, is good for your vision, controlling your diabetes, controlling your blood pressure, exercise. Avoid excessive noise exposure. So if you are going to go to I think the Rolling Stones have stopped touring now, right? Really? I mean, they keep touring, so maybe they'll never stop touring. If you're going to go see a concert, wear your earplugs. And continue to interact, because if you don't use it, you lose it. If you don't keep using your hearing, you will stop being able to process sound. So go out there and talk to people. Use something to help you. Hearing aids, the most effective and adjustable treatment. Yet only 10 to 30% of people who need them use them. Why? Well, they're expensive. Oh my gosh, they're expensive. Whew. And they're usually not covered by insurance, especially the really good ones that you don't have to put those little fiddly batteries in and they come on a charging station and they connect to your phone. Those are really expensive. Those are the Cadillac hearing aids. And you can't just pop them in and hear things. You have to get used to hearing aids, right? They're not just going to be suddenly like the world is full of music and light and laughter. You have to get used to them. So it's really easy to give up. And then people think everyone can see them, which is why I have the picture of the former queen up there wearing her hearing aid. You can't see it, can you? Now, I'm sure she got a very high-end one, but still, you can't see it. Sometimes, if that's not affordable or a reasonable option for you, a personal amplification device is really useful. In the clinic, we use something called a pocket talker. Looks like that. It looks like a little headset, little directional microphone. Kind of nice because it actually does a fairly decent job of tuning out background noise because it only picks up what's in front of the microphone. Right? So if you're in a crowded restaurant, sometimes it's easier to have a pocket talker with the microphone right in the center of the table so you can just hear those 4 people and you can ignore all those people behind you like screaming and yelling and whatever they're doing. Much more affordable. Also equally effective at helping your hearing if you need to. People ask me about brain games as prevention. So brain games as treatment are good because you got to keep your brain active. Brain games as prevention, usually you get individual benefits from individual games, right? You do the crossword, you get better at the crossword. It doesn't necessarily make you better at everything else, right? However, when we look at people who in their mid-80s have the brains of 20-year-olds, they do lots of puzzles, but they do puzzles that frustrate them. They think till it hurts. So the crossword puzzle will make you better overall if you really care. If you're going to do that Sunday New York Times crossword puzzle or die trying, that's the kind of thinking you need to do. So you want to do diverse, challenging, and interesting brain activities, not ones you can just sort of ignore, like Minesweeper, you just click the things and you lose and you do it again or something like that. You want to do things you care about. You want to learn a new language. You want to join a choir. You want to play bridge and really want to win the pot, something like that. Because most of the benefit may be due to the socialization. It's really hard to study the impacts of social isolation and socialization, and so the results from studies are often inconsistent. But when you look at the brain games that have the most data behind them, they're social games. They're playing cards, dancing, group gatherings, theater, museums, travel. So not only are they keeping you on your toes through other people, they're keeping you on your toes by challenging your brain to new situations. So probably the best brain games you can play are the ones that involve other people. Finally, sleep. Poor sleep is associated with, 1, being a doctor, 2, amyloid deposition in the brain, increased tau tangles in the brain, and these are both the molecules that are part of Alzheimer's disease. Decreased clearance of brain toxins. So your sleep is when you clean out your brain, right? And if you don't sleep, you don't clear out those toxins. It increases your levels of inflammation at all times, right? And inflammation in the brain is not a good thing. It decreases the amount of oxygen you get to the brain, also suboptimal. It makes it harder to control your blood pressure. It increases your risk of heart disease and heart attack. And it increases your risk of depression because if you're sleep deprived, you're not in a good mood. So UW has the 9 tips for sleep. Aim for 7 to 9 hours of sleep each night. This can be very hard, but aim for it. Prioritize your sleep. Get a good mattress and a good pillow. Right? They have lots of them out there that are much cheaper than they used to be. Make sure you have those good things. Your shoulders will thank you. Your neck will thank you. Start a relaxing evening routine that includes dimming the lights and not using the screens that are bright blue in your face. And having some peaceful thoughts. Think about world peace. It's nice. Limit your daytime naps to 30 to 60 minutes if you can. Don't sleep 6 hours a day and then expect to sleep 6 hours at night. It can be hard. No electronics or bright screens before bed. This is a great time for a book. Books are wonderful. Limit your caffeine in the afternoon and evenings. I feel bad saying that because I never stopped drinking coffee, but I'll have to give it up someday. Avoid eating right before bed. Exercise during the day, but not right before bed. And limit your alcohol intake because alcohol will make you sleepy right away, but then it also makes you wake up to pee about 3 hours later, and that's not great for your sleep at all. So make sure you're getting good sleep. So now you know. It's more than just memory that we're evaluating when we're talking about dementia. We do want you to watch for the signs, warrants investigation. Don't freak out. There's a lot of other causes, but get things looked into. Rule out all the mimics if you are having a concern. Get tested early, right? The earlier you get tested, the earlier you know, the longer we can buy you time for, and the more likely you are to be here when the really good stuff comes out in terms of treatment. And our medications can help, but exercise. So there it is. So time for questions. Thank you. This is my grandmother. Isn't she amazing? 96. Thank you. All right, gentleman in the front.
In the presentation, you used the word dementia once, and we're talking about Alzheimer's.
Yeah.
What, is dementia part of Alzheimer's, or are they two different things, and if they are, what's the difference?
Yeah, other way around, actually. So Alzheimer's is the most common cause of dementia. So dementia is the umbrella. Alzheimer's is one type. Yeah, good. And then there's a person behind you.
What do you actually die of when you have?
Ah, that is an excellent question. Many things, but to be perfectly morbid, 85% of people with dementia die of pneumonia. Yeah.
What's mild cognitive disorder?
Excellent question. So mild cognitive disorder, or mild cognitive impairment, is when you have at least one area of cognition that is impaired on testing, not just what you think, but on actual testing, but it hasn't impacted your life, right? You're still able to do all the things you want to do. And the reason we care is because about 50% of people with mild cognitive impairment eventually develop dementia, but we don't know which 50%. So we have to keep an eye on everybody so that we can figure out who's going where and who's going to stay the same. It's a good question.
The medicine that was shown on screen for cognitive loss,
Which ones?
well, I don't know. It was one.
It was one.
And I don't remember the name of it. I wish I would have had a pen.
So there's donepezil, there's rivastigmine, galantamine. Oh, rivastigmine is the Exelon. It usually comes in a patch form. And so they're all, those three, galantamine, donepezil, and rivastigmine, are all medications that improve acetylcholine in the brain and improve nerve connections. And they slow down memory loss and cognitive loss.
And that's prescription, not over the...
Yes, all the memory medications are prescription.
Can I hate to bring this up, but we have been diagnosed with aging dementia.
Okay.
What about caregiver?
Caregivers are very incredibly important. So I could go on for hours about the importance of caregivers and the importance of supporting caregivers and the difficulty it is to be a caregiver and how stressful it is. And I rail about how we don't give them enough time, money, or support. But everybody needs a caregiver. Everybody needs a caregiver. You got to take your accessory brain with you. Yeah, good question. There was another hand somewhere. Yeah, sorry.
So in my future, I'm going to exercise, starting today.
Yes, thank you.
What's the next most important thing I should do? You had a whole bunch of them up there.
Yeah, if I put them in priority, I would say exercise and eat your vegetables, and then sleep well and socialize with others, in that order.
Sounds like a party coming.
If you have a bunch of crudité and a whole bunch of people and you're all running around the table, that is a fine party by my standards. So we'll go him and then one.
I have a couple age questions.
Sure.
What are typical ages when these things really come to impact people? And is there an age range when most of that's probably behind you, and if you're at this age, you probably don't have to worry about it?
That's a great question. For example, if you haven't gotten diabetes by the time you're 80, you're not going to. So that's something to know. But in terms of dementia risk, the biggest risk is in your 70s and 80s. Now, part of that is because we actually don't have any testing norms for anyone over the age of 93. So we can't test you to know if you have dementia or not. But if you make it into your mid-90s, then, you're a winner on so many levels, right? At least as long as they're good 90s, right? Yeah. Thank you. And you had another question.
97, and she was having progressive dementia. All of a sudden, she got mean, very mean.
Yeah.
So they put her on a drug, and it made it worse because they said she had Alzheimer's. But then she was diagnosed with vascular dementia, and they put her on a different drug, and now she blows kisses.
Well, that's nice.
What do the drugs do to actually make them change so much?
Nobody knows. I wish I had a good answer. There are many, many theories. But we do know that at some point in time, 50% of people with any kind of dementia will develop radical personality and behavior changes. And our medications are more like Band-Aids than treatments. Yeah, it's a good question. Yeah, way in the back.
There's been a lot of negative press lately about statins.
Yes.
And I noticed that you know, some people go on statins for treatment, so how do you kind of reconcile that?
Yeah, so interestingly enough, so the one thing to know is that there was a quasi-study that came out that said statins increase your risk of dementia. That study was so poorly done that it doesn't necessarily warrant the paper it took to print the study. So I don't usually count that study amongst the data. Now, statins have side effects. Everything has side effects, right? So if you don't need them, you don't need to be on them. But in certain types of dementia, they do provide a little extra benefit. And so it's one of those conversations you have with your provider. Is it worth these potential side effects for me to be on this medication? That's very individual. So I would say that's a conversation piece, as it should be with any medication you go on. Yes, sir.
Do you have any recommended literature?
So there's a lot of literature out there. I'd have to pull up a different list. I'm sorry, I'm having a senior moment right now. Yes, we have a list at the clinic. So I'll try to get it to Katie, the reading list.
Thank you.
Thank you, yeah.
Would you explain the difference between dementia and Alzheimer's again?
Yeah, sure. So dementia is an umbrella term in which there are 38 to 40 different kinds. Alzheimer's is the most common cause of dementia. So probably about 60% of dementia is Alzheimer's and 40% is all the others. Yeah, it's a good question. Yeah.
Has there ever been a study done with Alzheimer's, men or women? Who has it more, a man or a woman or?
Yeah, no, there are many, many studies looking at the demographics of Alzheimer's. Men tend to be a little higher risk than women. And people who had very poor early childhood education experiences are at much higher risk. So there's all these different demographic breakdowns. If you ever want to see, I think the Alzheimer's and Dementia Research Center, ADRC at UW, has a good pictogram of all the different breakdowns. And there's a lot of researchers looking into all of that here in Madison, actually. Yeah, yes, sir.
What is Lewy body disease?
Excellent question. So Lewy was a pathologist, but a Lewy body is a type of abnormal protein in the brain, and it gets into certain sections of the brain. It's very different than Alzheimer's, and it causes some memory changes, but it mostly causes lots of weird sleep changes, movement changes like Parkinson's disease, and hallucinations. Causes weird visual hallucinations, usually of little creatures. But it gets worse, and eventually you do lose your memory. It's an interesting and difficult disease, but it's much more like that than a straight-up memory disease. Yeah. Oh, yes.
How important is a fall?
Do you have any questions?
That hurts your head badly.
Yeah. So how important is a fall? Well, falls are amazingly important for many reasons. And maybe the head injury part is less important than the hip injury part. So we know that pretty much everyone over the age of 80 falls once a year, and less than 30% of them tell their doctor. But falls cause the vast majority of trauma in older adults, and if you break your hip, that is a 20% mortality at 1 year, and a 50% chance that you'll never return to prior independent function. So I am less worried about the fall with the head injury than I am about the fall with a hip fracture. Totally different talk, but a very important one. Thank you.
Can you say that statistic one more time about
Falling?
Yeah.
So if you fall and break a hip, the 1 year mortality on that is 20%. And there is a 50% chance that you will never return to your prior level of function. So only a 30% chance that you'll be back to normal again after you get better from that hip fracture. So please don't fall. So question in the back.
My husband has PCA.
Yes.
Which is very rare.
Very rare.
he's known it for almost 3 years. Has there been any more research in the last 3 years?
Not much. Rare diseases have rare studies, right? That's the unfortunate part. We know so little about the common dementias that the rare ones get shifted to the side. I wish it would be great. It's a very rare one and very difficult. Yeah.
So is there statistically just more dementia now, or are we just more aware of all the dementia?
Yeah, probably a little bit of both. So one part of it is that we're living longer. Other things aren't killing us off first, so we live long enough to get dementia. We're much more aware of it. We don't call it going senile anymore. We know that's not true. And it does seem that there is more of it. So there's something else going on.
And you hear younger people, I refer to them because I just heard this discussion the other day about environmental exposures.
Yeah.
And the aluminum and the antiperspirants and the hair coloring.
Yeah, I'm much less concerned about aluminum. So the aluminum data came from early dialysis days when the solution for dialysis had a lot of aluminum in it. So it's probably not that. There are many other potential environmental exposures that we don't understand the meaning of lead. I mean, Milwaukee's lead paint problem is probably a really big deal, but we don't really know. And so all the other things that we've put in the environment, we don't know their impact at all, and that's very hard to tease out. But so it's I don't know that we'll ever know fully what that has done to us. Yes.
I know you're familiar with Dr. Sanjay Gupta.
Yes.
Okay, the young man there, I think you asked about a pamphlet or books. He has an excellent book out.
Yes, he does. You're right.
It now.
Yes.
I'm reading it now. It's really great.
Yes, Sanjay Gupta is a good writer. That's one author to look up. Yes.
What was it? I didn't hear her.
Dr. Sanjay Gupta is his last name, Gupta. He's got a good book on memory, and I'm trying to think. Yes, I will try and find that list. Dr. Chin is the memory doctor who compiled the list, and I will pull it out. Yeah.
On the tape, what was the reason that you said for falling backwards?
So certain types of dementias have a tendency to fall backwards instead of forwards. So Lewy body disease, or if you have Parkinson's disease-related dementia, which is not everybody with Parkinson's disease gets dementia, by the way. But if you have those kinds of dementias, you might fall backwards. Yeah. It's one of those weird things. Yeah. Okay. Yes, sir.
You mentioned statistics related to breaking a hip.
Mm-hmm.
What's the relationship between that and a hip replacement?
The hip replacement fixes the hip, fortunately. So if you had a hip replacement just because you needed a hip replacement, that's not connected at all. If you get a hip replacement because you fell and broke a hip, you have a slightly better chance of returning to normal and much less chance of dying. But it's still a fair decent chance that you will not really be quite the same ever again.
So what's the reason for that statistic then? Because I'm a nurse and
why do people die from breaking their hip?
Yes. What is the reason?
So it's not usually the hip itself. It's all of the stuff that happens after you break a hip. The infection risk, or you're just not able to get up and do things for yourself and you get something, it's all of that kind of downstream thing. People dwindle after hip fractures. So it's never just one thing. But you're right, people just are not like directly dying because their hip is broken. But they may lay on the floor for a long time. And that has a lot of downstream effects. Yeah.
So at this juncture, are you hopeful? Is there exciting research coming? Is there more awareness? Like, where do you see things going?
Oh, that's a great question. I am always hopeful. I'm a perpetual optimist. It's useful in my job. So there is exciting research. There's very exciting research, a lot of which is done at UW. There is great research. One of our big areas is in better imaging, better tests, finding it sooner. While I am not completely, personally, this is my bias, I'm not completely convinced by the new infusions that are out there on the market. A lot of us weren't completely convinced about the chemotherapy when it first came out, right? You got to start somewhere. And then you get better medications over time. And so I think that day is really coming. I'm very excited about the new blood tests because, again, finding it sooner means we can intervene sooner. So I think there are really good things coming. And we're talking about it right now, right? And we're talking about it with people who don't hear about it very often. So I think that's the other part, making sure that people in all the communities get the message. We haven't really gotten the word out to everybody.
Hip replacement, with or without an accident, is much, much, much less complicated and difficult than it used to be.
Hallelujah. It's true. Hip replacements are better and better and less invasive all the time, and our orthopedic colleagues are really very good at their jobs. Yeah.
You have ongoing studies about this topic?
We do. Oh, this is my chance to proselytize? Absolutely.
Okay, so how do we volunteer? Do we get involved in it?
Yeah, so to get involved in research, you go to the Alzheimer's and Dementia Research Center website at UW, and they have at least 8 studies running at any given point in time looking at different things. So there are the big cohort studies that keep track of people year in, year out who don't have dementia, just to kind of see if they can see what all your risks are and add all of that up. There are studies investigating, are there demographic differences between the Black community, the Latinx community, the white community, and environmental exposures and childhood poverty and all of these other injustices that have been dealt to different communities over time. There are studies on sleep quality and aging. There are studies on the microbiome and brain health. There's lots of studies out there. I personally do not do any research, but I do love to talk about the smart people in my group that do. Yes?
You see a lot on TV about a med called Prevagen?
Yes.
And is that like a scam?
Yes. Prevagen is ground up jellyfish protein. If you would like to eat ground up jellyfish, I can recommend an excellent Chinese restaurant in Madison that serves a wonderful jellyfish salad. Much cheaper. Won't help your brain. Maybe on that note, I think we're probably at time. So yeah, but I will, I don't know how to connect all this, but I will stand around here for a few minutes.
Well, thank you so much. This was so fabulous. Thank you so much to Dr. Eastman. Thank you so much to all of you for all of your wonderful questions and engagement. I really appreciate this. And I'm glad that you brought that up about the risk of falls, because our next Lunch and Learn, which is going to be in July, is all about falls prevention. So,
oh, good. Who's coming?
From Safe Communities. I can't remember the name.
Okay. Mary Lobby, maybe. Anyway.
Maybe. Be on the lookout for that. So that's coming up this summer. So I hope you can attend that. And we are also doing a 7-week session with Ellen Taylor of the ADRC, Aging and Disability Resource Center, is going to be doing a series workshop called Boost Your Brain and Memory. I know there is 1 spot left on it. So if you're interested in that, there's information up at the front here. That's going to be happening in June and July. So wonderful. Again, thank you, Dr. Eastman. Thank you, everyone, for coming. And I hope you come to our next one, too.